things are coming out so quickly, which is a blessing to patients, right? But boy, trying to keep up on it's a challenge. It's a challenge.
I'm sure that there's a lot of nurses who've been in oncology for a long time prior to navigators who are feeling like, how did we do this before?
Yes. Have a plan, because you know what happens, right? It's Murphy's Law. No one ever has a toxicity between 9 and 5 on Monday through Friday. They all have their toxicities at 4 a.m. on the weekend, and their physician isn't on call.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are joined by ONS member Kristi Orbaugh, nurse practitioner for Community Hospital Oncology Physicians in Indianapolis, Indiana, and member of the Central Indiana ONS Chapter, to discuss how to address knowledge gaps regarding immuno-oncology. Kristi is here to share findings from an ONS focus group she facilitated on the topic on August 5th, 2021. The group discussed immuno-oncology, specifically navigation, precision oncology, and immune-related adverse events, irAEs. This podcast episode is supported by an educational grant from AstraZeneca. ONS is solely responsible for the criteria, objectives, content, quality, and scientific integrity of its programs and publications. Thanks for joining me today, Kristi.
Thank you for having me.
So let's start with talking about the first discussion point from the focus group, navigating patients through immuno-oncology. What is the role that the nurse has in coordinating care, such as patient education, tests, scans, and follow-up?
Well, I tell you what, Stephanie, one thing we found out very, very quickly was that navigation is different in every setting and every institution. I want to just give you a little background. ONS did such a beautiful job of, I'll say, handpicking people to participate in this focus group. We had folks that were true navigators. We had managers, we had infusion nurses, we had NPs that worked in an oncology ER, we had everything in between. And it was so interesting. Some places had many navigators that worked in disease-specific roles. We had other places that had more lay navigators that worked in more financial navigation, social work navigation, that type of thing. And then we had a lot of folks on the focus group that really didn't have a true navigational program. But what we found out, even though all of those settings and how they used navigation looked very different, even for the folks that didn't have a true navigation program, oncology nurses were stepping up and navigating their patients through this journey. And, we see that historically. I've been in oncology a long time, and we didn't used to have navigators. I'm so blessed. I work at an institution that has a very, very strong navigation program. And there are days I wonder how we ever got through a day in clinic without navigators. But as oncology nurses, we took on that role as navigators, whether we had that program or not. And that was one of the things that I thought really stood out. As far as navigation within immuno-oncology, that was very interesting because, we talked a lot about, well, who does the teaching and how is the teaching different if you're, discussing chemotherapy regimens versus immunotherapy regimens versus are you putting a patient on a TKI? and how all that looked as well.
You're right. I'm sure that there's a lot of nurses who've been in oncology for a long time prior to navigators who were feeling like, how did we do this before?
Yes.
And remember back to, wow, we really did a lot of extra work, but just the benefit that navigators have really brought to practice. So as you were talking to this group, what new challenges did the group report with immuno-oncology that were different from other therapies that they might be helping navigate the patient through?
Well, for one thing, toxicities with immuno-oncology can look different, right? They can present different. We talked a lot about the predictability. Let's just say for a moment, I'm a breast cancer patient and I'm going to get my very first dose of adriamycin and Cytoxan. When that nurse navigator or oncology nurse or infusion nurse, whoever is going to do that teaching, they can tell me when my counts are going to nadir. They can tell me when I need to start my home oral medicines for anti-nausea because they know exactly when the IV antiemetics are going to run out. They can tell me even almost to a day or two when my hair might start to fall out, when I might start to get mouth sores. Because for the most part, our toxicities that we see with chemo are fairly predictable. Now, there's a little variation patient to patient, but for the most part, they're pretty predictable. When we sit down and try to talk to a patient about going on immuno-oncology, we know that those toxicities are not nearly as predictable, which makes going through that educational process and trying to support and equip the patient as well as their caregiver with information to watch for and notify the office for can be a little bit more challenging. As you know, some toxicities that we see with immunotherapy can actually present months to years after the immunotherapy has been completed. So that was one real rich conversation that we had, as well as, and I'm sure we may not have time to cover this today, but then the whole piece of if a patient is on an oral medication, how do you track that adherence? How do you talk to them about the importance of taking that on a regular basis as prescribed? Those were some of the highlights of that particular conversation, I think.
That sounds like it was a very rich conversation and just so many things that the navigators have to take into consideration and really remember and talk to the patients about. So did they talk about any of the solutions that they've come up with as navigators to help, that whole process, whether it's education or, helping patients monitor the irAEs?
Right. And actually, that, Stephanie, might have been one of the gaps that we found. Each facility, each clinic really had a different way of tracking toxicities and asking patients to track those. And we found that there was inconsistency within each facility. Now, that's not a criticism at all, but we just really talked about how it would be so beneficial if there was just one universal way to track that. Now, maybe not as in within the entire United States, but universal within each system. So when a provider came in, they could either pull up something on the EMR or that showed them exactly the toxicities that the patient had had with that particular cycle. The nurses could see it, the pharmacists could see it, the navigators could see it, and then how the patient might monitor and document that at home. Was it a take-home piece of paper? Is it a journal? Is it an app? Those were some gaps that we felt like maybe as ONS could take back and kind of put their heads together and see if they could come up with tools that might be helpful. one thing that came up over and over and over again was that places are short-staffed, right? That's not a revolution to anyone, unfortunately. Clinics and hospitals are very short-staffed now. So our time is precious. So we talked about the need for patient education tools that were kind of down and dirty. This is really what you need to know. This is the vital, meaty piece that we could use with a patient that would be very beneficial and yet minimize hours in teaching.
Yeah, I can see where, that gap, like you mentioned, would be, and how frustrating that might be when, navigators are working with the, clinic nurses and working with the physician or the NP on a patient and how their treatment is coming along, but yet that consistency, like you were saying, is not there to be able to see what has happened and how their treatment is going and how they're responding and how the irAEs are presenting for each patient. And so I could see that is definitely a priority, for that group to try to find a way to standardize, like you said, and not across the US, but in institutions so that everybody does know where to look and what they're looking for.
And in doing that, it's like then within that institution, we're all speaking the same language, right? We know right where to go. We all know that this patient had X amount of stools or had nausea on this many days. And we're all just really on the same page.
Exactly. So in talking about the irAEs, what did the group discuss as far as how nurses are responding when patients present with irAEs and kind of how they are doing things to keep that communication open across the board in their setting?
Well, what I thought was really enlightening, and I guess I'll use the word encouraging, so many of these nurses, they were acting very, very proactively. So, Stephanie, you're my patient, and I've done my teaching with you. You're, on getting ready to start cycle 1. You know when to start your oral antiemetics at home. You know you have phone numbers to call. You have a thermometer, a working thermometer at home. You have maybe mouthwash solution at home ready to go if that's a very common toxicity. You have Imodium at home ready to go. And so these patients have a plan because you know what happens, right? It's Murphy's Law. No one ever has a toxicity between 9 and 5 on Monday through Friday. They all have their toxicities at 4 a.m. on the weekend, and their physician isn't on call, or the drugstore isn't open. And so making sure that patients have a plan. Here was the other thing that, I work in Indianapolis, and so we worked with a lot of folks that are in a more rural community. And patients sometimes would go to their primary care physician about something. And understandably, the primary care physician may not be up to date on, all immuno-oncology and the possible toxicities and how an adverse reaction might present. And so there was that piece of we need to educate our patients, but boy, do we need to help educate our colleagues as well. Because everyone in medicine, from MAs all the way up to physicians and everyone in between, we all really want to take good care of patients, right? But if we don't have that knowledge, we might miss something or maybe not suggest the best solution simply because we don't have that information. So we talked a lot about if we have to send a patient to the emergency room, the importance of really making sure that you're giving report to the emergency room. Look, this patient has shortness of breath. Yes, we need to think about pulmonary emboli, but they are on immunotherapy. We also need to be thinking about immune-related pneumonitis. They also have lung cancer, and maybe this is progression of disease. So the importance of, sharing that information with those folks. a lot of patients on immunotherapy, they made sure that they have a card to carry in their wallet or their billfold that has exactly what they are on, but more specifically says, I am on immunotherapy. Make sure you call my oncologist before you prescribe XYZ.
Yeah, I think that's so important. And, you've really just kind of touched on a lot of the communication issues that I'm sure are being experienced by clinicians across the board, with the navigators, the nurses that are in the treatment rooms or the hospitals, and then their clinical providers. And you gave an excellent example, because you're right. It does happen at 4 a.m. on Saturday when the clinic is not open and there isn't anyone to talk to. So making sure that patient gets the education that they need, like you said, the identification card or something like that, but they know who to call, they know what kinds of things to tell if they do end up going to the ED, tell the staff there so that they can make sure they're getting looked at in the most appropriate way.
Florence Nightingale used to talk about in one of her articles about the power of words and how those were some of our very best tools. And I always think about that because we do go to work as oncology nurses with this toolbox, to manage a variety of toxicities. We know how to manage neutropenia. We know how to manage nausea and vomiting. We know how to manage stomatitis. But one of the most important tools in that toolbox are our words. Communicating with the patient, communicating with the caregiver, communicating with our colleagues. And we can't forget how important that communication piece is.
Exactly. It's so very important. You're right. I'm going to kind of change our direction for a minute here and talk about one of the other areas that the focus group discussed, and that was precision oncology. What foundational knowledge is critical for nurses working in this area of cancer care?
Precision oncology used to be called personal oncology, personal treatment plan. And we now know that it's not only vital to identify any genetic mutations that might make a person more at risk for one malignancy or another malignancy or a group of malignancies, but it's also absolutely vital that we look at the mutations within that tumor. So we're looking for a mutation that might be driving that tumor to grow and divide without regulation, to grow and divide without any regard for cells and structures around it. So when we talk about precision oncology, we're looking at both of those pieces. We're looking at, does the patient have a genetic mutation, or does the tumor have mutations that are actionable? And what we mean by actionable is there a medication on the market that can target and block that particular mutation that's signaling an abundance of signals to the nucleus of that cancer cell, telling it to grow and divide, grow and divide, grow and divide. And so when we do that mutational testing on tumors, sometimes that can take a while. Tissue testing can take up to 2 weeks. A liquid can take somewhere around 7 days. Well, if you're a new patient and someone looks at you and says, you have cancer, now we're going to wait 2 weeks to know how to treat you, that can be very, very concerning to a patient. Understandably, they weren't treated yesterday, right? So again, using our words to make sure that the patients, their loved ones, as well as other colleagues, understand the importance of looking for those mutations and waiting, if at all possible, to see if there's an actionable mutation, an actionable driver that we have a medication for, because that can be much more efficacious than just treating the patient with, let's just say, a one-size-fits-all type of treatment.
I think when you're talking about precision medicine and how important it is, like you mentioned about Florence, talking about communication, it's so important to understand that and be able to talk to your patients about that, because like you mentioned, telling them that they just, them just receiving a cancer diagnosis, and then, like you said, now we're going to do some extra testing that's going to take 2 weeks. When they've probably already waited 2 weeks to get the appointment and then 2 more weeks to get this, that seems like a lifetime to them. And they just want to get started. Why can't I start my treatment tomorrow? Why do you have to do that? And just to be able to explain how important it is to have that testing done, and for not only for the patients, but for the nurses to understand what biomarker testing is, because those tests, that Gen X sequencing and things like that, there's a lot of information on those results. And to be able to understand what kinds of things we're looking for patients, for specific diagnoses and things like that is really important. Did you talk about in the focus group what some of the knowledge gaps might be regarding biomarker testing for immuno-oncology?
We sure did. And that was an area that we felt like nurses and those working in oncology could really benefit from educational pieces or more conference-like, lecture-like information where a nurse could actually log on and listen to a conversation about precision medicine or understanding biomarkers. We're still relatively new in this topic. And if a nurse is an infusion nurse and working very hard with, hanging the chemo and educating the patient on chemo and these types of things, they may not have a lot of face-to-face time with like the oral TKIs that we use, or the drugs that are specifically used against some of these mutations. And so there really can be a knowledge gap there. And how can we as colleagues help educate them? And how can ONS, how can you help develop tools and educational programs that would really benefit and increase the nurses' oncology knowledge about this particular topic? I have to tell you, even though I work in it and I understand to a degree about precision oncology, in no way, shape, or form am I saying I'm an expert, not at all. I'm just saying I understand probably enough to be dangerous, right? But if I were diagnosed with cancer or my loved one was diagnosed with cancer, even knowing what I know, that waiting period would be very hard. Let's wait until we get this testing back. Even with that knowledge, that waiting period is very, very hard.
I agree with you on that, about the waiting period and about the education. I think that, we're seeing that is definitely a gap that oncology nurses specifically have, but the patient, then giving that information to the patients, just where those gaps are and how that is definitely something that we need to increase education on.
Just to give you an example, and I know you have hundreds of examples, and those listening to the podcast have hundreds of examples, I'm sure as well. But I have a patient in my practice right now, diagnosed very recently with a non-small cell lung cancer and was really pretty asymptomatic. And as you know, non-small cell lung cancer has kind of become the poster child for precision medicine recently, right? With all of those mutational drivers that have been identified. And this patient was very anxious. Her family was very anxious, all understandably, and really tried very hard to push for us to go ahead and start chemo. But her oncologist really wanted to wait for the mutational burden and mutational panel to come back. And again, keeping in mind, she really wasn't in any imminent danger. She was pretty asymptomatic. She ended up with a MET mutation. We were able to start her on a drug that was appropriate for that MET mutation. And within 6 doses of taking that pill, all of her palpable lymphadenopathy disappeared within 6 doses. So I try to keep that example in mind when I feel anxious and I'd like to start a patient sooner rather than wait. Just finding what was driving her tumor to misbehave and having a medication that blocks that. You should see her running around. She exercises every day, loves to do yoga, travels with her family. I mean, getting her to come in once a month so we can look at her, getting her to work us in her social schedule is the biggest issue we're having with her right now.
What an excellent example of that, and how important it is to have something like that to explain to patients. And, unfortunately, not every patient is going to have that kind of outcome, but to explain how important it is, because you're right, when you are able to target the exact mutation that is causing the problem, it's amazing that we do have treatments that can have that kind of result, and how important it is, how exciting it's going to be when we have more diagnoses that have that ability. And things are happening so quickly that I hope that will be the case for so many other cancer diagnoses as well.
That brings up another point that we did talk about, Stephanie, is things are coming out so quickly, which is a blessing to patients, right? But boy, trying to keep up on it's a challenge. It's a challenge. And so again, that brings home the point of educational tools for nurses or programs that they can log on and listen to. Because our education, we cannot be complacent in oncology, because we have to have our track shoes on and running all the time, because things are changing. This is a fast-paced specialty.
That's so true. So, Kristi, from this whole focus group experience, how will the findings that came about based off of the focus group kind of shape ONS clinical priorities in the future, or what are some of the next steps based on the findings?
Well, we spoke a little bit about earlier, Stephanie, just the importance of having kind of 2 different types of education. Very quick, concise, major point educations that a nurse can pick up and go, okay, now here's the drug, or here's the subject, and the 5 really main points I need to know and understand so I can, number 1, take better care of my patient, and number 2, educate my patient well. That's in general. And then more about specific things for understanding precision medicine, understanding that mutational testing, understanding the difference between liquid and tissue testing. That was really important. Then another thing that came up is our regimens are so complex. There are many, many regimens that use IO therapy as well as chemotherapy. So we're using immuno-oncology and then attaching it to a chemotherapy regimen. We're now starting to see regimens and studies. Can we use TKIs in addition to IO or in addition to chemotherapy? Can we try to block that driver, that mutation, as well as, give alongside another treatment? So then think about how complex and crazy that can make trying to discern toxicities when a patient comes in. So say a patient comes in and they're on IO therapy as well as chemotherapy and they have diarrhea. Do they have immunocolitis? Do they have kind of just regular chemotherapy-induced diarrhea? Did they eat something that didn't settle well with their stomach? Have they been on multiple antibiotics and now they have C. difficile? So how do we start working through that differential diagnosis and start teasing out those symptoms so we can identify the cause and treat that toxicity, that adverse reaction appropriately.
Yeah, that is really important. And like you said, just the understanding the complexity of these treatment regimens is so different now than it was before, when, you were just giving kind of the gold standard chemotherapy. So, now there's just so many different drivers that might be causing these irAEs that are really important. And like you mentioned too about, having our track shoes on, you've got to kind of be able to, look at a regimen or look at that whole patient picture and pick out what could all of those possibilities be, like you just mentioned, and how that's a lot of information to know. And if each patient has a different regimen and you're trying to remember all of those things, that's an important thing to make sure that we have the knowledge that we need and the resources that we need to be able to do that and understand it all.
It is. I tell you what, when you think of what all knowledge an oncology nurse carries to work every day, it's pretty amazing.
It is. This has been so interesting talking to you about the focus group and what you gleaned from talking to those nurses in such different roles and finding out, areas that are gaps in knowledge and processes that need to be improved, or we need to figure out ways to kind of complete the communication circles and things like that. And I've really enjoyed talking to you about that. I have a couple of questions that I like to end our podcast on. Some of them we've touched on a little bit, but I just wanted to ask you these in thinking back on the focus group and what you talked about. First of all, what are some common misconceptions related to precision medicine?
I think that there are a lot of misconceptions, not necessarily misconceptions, maybe just lack of knowledge about precision medicine. What exactly does it mean? What is a driver? What is that? What does that mean? What's an actionable driver or an actionable mutation? I think that those are all things that we could all get more knowledge about, understand more in depth. Also, the importance of sending those tests. We can't treat a mutation if we don't know that patient has a mutation. And you think about that, kind of compare it to breast cancer, if you will, just for a minute. We would absolutely never think about treating a new breast cancer patient without knowing whether their tumor was hormone driven or whether they had overamplification of HER2, right? We would never think about choosing a treatment for a patient, a breast cancer patient, without those two vital pieces of information. That's precision medicine. So we need to take that and think about that in other diseases, in our colon cancer patients, in our lung cancer patients. And we need to have as much information as possible about that particular tumor so we are able to pick the very best treatment for that patient.
That's really important. And I think it's something that we need to understand, and nurses need to understand the importance of that no matter where they work. Because from my personal experience in working in an academic center, you feel like you have access to those tests much more readily than sometimes the community sites might. And so for nurses who are working in those rural and smaller community sites, just understanding that so that that communication can be made and they can advocate for their patients.
Exactly. And we talked about that. But it doesn't matter whether a nurse works at a large academic setting or whether they work in a very rural setting. oncology nurses across the board just want to take really, really good care of their patients. And so we need to equip them. And I encourage you at ONS to equip them with tools to increase their knowledge. So regardless of what setting the nurse is in, they have the knowledge, they have the tools to take the very best care of their patient possible.
Exactly. I agree with you on that. So talking about those tools, and you've talked about, that the focus group really identified, or based off of the conversations you had with the focus group, that there are definitely some gaps in education and training. But were there any resources, until some of those other things are created, were there any resources that were talked about that nurses can use to help with these patients that are on immuno-oncology treatments?
Right. Yes. We talked a lot about following NCCN guidelines and how it's really important that what we're recommending to patients is truly evidence-based. The other thing we did recommend, and many of the folks in the focus group use your PEP cards. So looking to ONS for guidance and, education programs that are set up as well. ASCO has really nice guidelines and recommendations for treatments. So looking at those three main, NCCN, ASCO, ONS, those were the big ones that we talked about really seeking evidence-based knowledge from.
Well, thank you. That is definitely a good recommendation for folks to go to, as the information gleaned from this focus group is taken back, and hopefully some new and good projects will come out of the information that you guys had. How interesting it must have been to just be able to talk to that group and get all that feedback and really hear what is happening across the country and what nurses are dealing with and how they are doing the best job possible at taking care of their patients. That must have been really an interesting and fun thing to do, to be part of.
It was such an honor and a blessing to be part of it. I have to tell you, when they said the focus group will be 3 hours, I was like, oh my gosh, what are we going to talk about? 3 hours went by in a blink of an eye. And, the focus group folks were able to unmute themselves and chat out loud. But then there was also this chat going on in the chat box. And over we heard, how beneficial the information was and how they got such good information from each other and exchanged contact information because certain people, had tools that they recommended and others wanted to benefit from those or learn more about those or, just connect as colleagues after. And it was incredible.
I'm sure it was. And what a wonderful way, like you said, to network and start those relationships with other nurses that are going through the same thing. Because how many times have we all felt, as we're down in the trenches, who else is going through this? Who else is having this problem that I could talk to about, and we could brainstorm what some great ideas we might have or ways to help our patients. And like you mentioned, that's what all nurses want to do. They just want to do the best they can for their patients. So Kristi, I want to thank you so much for being with me today and just talking through this and talking about that experience. Do you have any final comments for us before we leave?
No, I just encourage anyone that listens to this podcast. There are a lot of really nice educational pieces that ONS has to offer. Make sure to log on to that site. And also, I encourage you to, network and talk to your colleagues because, as you just said, we learn a lot when we're down in the trenches. And I haven't met an oncology nurse yet that hasn't been more than willing to share some pearls that they have learned down in the trenches.
Thank you so much for joining me today, Kristi.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.